Webb was presenting things you can do for yourself and for the patient. What we're going to have Dr. Hobson talk about here is now you're in charge of a team, and whether that's in a private practice with your own employees, or an academic center with people training under you, or just in the OR with 5 other people or 10 other people looking at you for what to do. It's a big transition from training. So I'll let Dr. Hobson take that away and tell us what she knows.
Good evening, everybody. Dr. Webb, great case. Thanks for sharing. All right. All right, good evening, everybody. For those of you who don't know me yet, my name is Sandra Hobson. I am a new spine surgeon. I'm on faculty at Emory University. I just joined the faculty in September of 2020. And Dr. Webb was talking about, you're the captain now, understanding pre-op planning, which was excellent. And now I wanted to talk about a related topic. You're the captain now, leading the team. I have no relevant disclosures. So some learning objectives for my quick talk are get a basic understanding of one 5-part theory of good leadership, as well as understanding what a sphere of influence means and how to potentially expand it. So leadership is very hard to define, and I don't know if some people read Harvard Business Review or one of the thousands of leadership books that are out there. But there's many different strategies on leadership and even what makes a good leader, what are good leadership qualities. And physicians actually somewhat rarely receive formal leadership training. And I think it kind of hinders us in some cases. So I wanted to talk about one 5-part theory that I particularly appreciate of good leadership. And this is actually adapted from MIT. So they have some courses on the basics of leadership and such. And this is one of my personal favorites that I decided to share with you today. So there's 5 components according to them. So one is know yourself first. And the second is know your organization. The third is know your team members. The fourth is set your vision and trajectory. And then lastly, the 5th one is manage the day-to-day operations of people and tasks during this. So for number 1, know yourself. I think this is a tough one for surgeons sometimes. So why are you a leader? How did you become a leader? Most likely you told yourself, well, I want to become a doctor, and you went to medical school and you liked neurosurgery, orthopedic surgery, and then you eventually liked spine, and then suddenly you're a doctor and you're also a leader. And during that journey, I think some people don't realize that when you step into the role after training, you are inherently a leader just based on your position. And what are you going to do about it? How are you going to be a leader? And things to know about yourself. Dr. Webb mentioned this. I think you really need to know yourself to understand how you're going to react, and also how you're going to react in a tough situation. So why do you get angry? And then what do you do when you get angry? What do you do to underperformers? Do you yell at them in front of everybody? That's probably not a good idea. How do you inspire people? Are you someone who's very charismatic? Are you more a leader by example and less of a talker than some others? And then how do you achieve common goals with the group? And I think these things are very important. You know, Dr. Webb mentioned not getting angry. And I think that a lot of things can go wrong in pre-op planning and potentially during surgery. I work at a level 1 trauma hospital, so I do a lot of emergent cases. And I have to say, I wish I could have more time for pre-op planning in some of these cases, but you know, you have to stay calm and you have to be in control, even in an emergency where you don't have as much time to plan as you'd like. And so when you're stepping into the role as a leader, you just can't lose your temper. You can't get angry. You can't throw things. You want respect. And so you need to treat other people with respect. And people generally judge you by your worst moments. I mean, you can have a bunch of cases that go well and you're really nice, but the one time that somebody loses their temper and throws things, I mean, everybody's going to know, and everybody is going to be afraid of that person. And the worst thing about it is it destroys this sense of psychological safety. And the most important thing, hopefully, for you and your practice is taking great care of your patients and your patients doing well. And if nobody feels safe to talk to you, if they feel like you're just going to yell at them or get really angry, they're not going to bring things to your attention that could potentially save your patient. So number 2, as a good leader, you should know your organization. And so this is true whether you go into private practice, whether you go into academics. So get a sense of what your organization is good at and what it's bad at. Oftentimes, there are 2 more general themes. So oftentimes people join a small to medium-sized private practice group that tends to be more nimble, more flexible. The surgeons tend to have more autonomy and more control, but it is more prone to risk. And so how to manage those risks as well as the advantages. And in contrast to that is the classic lumbering academic institution, which it's large, it's very hard to get change done. You know, you feel like it can be very bureaucratic. However, you and others are more protected from risk. And for example, one of my assignments is actually at the Veterans Administration working for the federal government. You know, I mean, nothing changes very quickly there, but also it's not going to go bankrupt anytime soon. So that job will be there for a very long time. And this is also important in understanding your role as a leader as far as expectation goes. So, you know, if you're working in an academic institution and their turnovers are currently an hour and a half between cases, you know, you coming into the OR and just yelling at everyone, telling them to do a faster turnover is not going to work. You can take that on as a quality improvement project. You can look at underlying reasons. You can try and have that as a long-term goal if you're interested, but you need to understand what your organization is good at. And especially as a young surgeon, really try to choose your battles and choose your battles that the organization is going to be able to achieve and is good at. So for number 3, start to know your team members. And I think I like to distinguish between the team role and the individual, him or herself. So as part of a team, often everyone has a designated role or an assigned title, especially in medicine, and there's kind of an established hierarchy. So perhaps you are a nurse, perhaps you are an APP, you know, a PA or NP, perhaps you're the attending surgeon, perhaps you're an intern, a spine fellow. So that's kind of that person's role on the team. And while there are general concepts of what each person in each role should be doing, I think sometimes this is surprisingly unclear. And it's great to establish what expectations are for a specific role. So even if you have in academic practice a resident that rotates on your service, with each new resident, it's a great idea to just sit down, even for just 15 minutes, and say, hey, these are my expectations for your performance and your role as a resident during this time. So I see your role as incorporating X, Y, Z. And because of that, my expectations of you are ABC. And then you can expect the following of me. You know, what questions do you have? How can we work this out? And I think that that helps bring a lot of people on the same page who are coming from different backgrounds. And then once you, as a leader, understand the different roles on your team, I think you need to then understand each individual human who is currently occupying those roles on your team. So perhaps you have a nurse practitioner who hates being in the operating room. You know, her interest long-term is to build her own clinic. She really appreciates the autonomy of decision-making in clinic. So perhaps that person is better suited to be in an extender clinic for you, as opposed to being your assistant in the operating room. You know, perhaps someone, you know, maybe you have a PA who is just technically great, but a little bit blunt with patients, maybe not the best bedside manner always. You know, maybe you can have that person assisting you in the operating room more. and in the meantime, try to improve some of his patient care components. And so that's why I think you need to know your team members, but think about them in two ways. So one, their specific role, and then two, what they as an individual human bring to that role with their strengths, weaknesses, and long-term future goals. And another thing I wanted to talk about under here, you guys probably have heard this statistic from the Joint Commission. It's now fairly dated. However, I think that it still holds true in many cases that communication errors are the root of greater than 70% of sentinel events in healthcare organizations. And so if you are the team leader, it is your job to facilitate communication and to make it happen. So you need to confirm that the communication happened. You need to be the one who's leading the communication effort. You shouldn't be the one waiting to hear back from somebody, you're like, oh, well, I hope so-and-so did that. Who knows? You know, you need to be the one, especially when you're young, to be proactive, to be confirming, to be very clear, to ask for feedback, not only feedback from your mentors surgically, but also feedback from your team members saying, hey, how can I communicate better with you? And one of the things that I've been trying to do, I know Dr. Webb was talking about how he prepares for his operative days by handing cards to some of the members of the OR team, which is great. I have done some cases at the Veterans Administration, and I would post the cases requesting certain things, such as a microscope, you know, and I'd get there early and the microscope wouldn't be there. And it's just harder for them to get everything ready. And when I was trying to figure out why this like lapse in communication was happening, even though I communicated to my surgical scheduler, the bureaucracy basically has so many layers between that communication and what reaches the operative team that I think my preferences weren't actually getting across. So I started a new kind of de-identified Microsoft Teams document where I kind of put in all my preferences personally, and then other people can log in and see kind of de-identified what my preferences are for an upcoming case. And now actually they set it up all the night before. And, you know, it's honestly been so much better. And I think that that's one thing that I tried to do to help improve communication on my team. And I think it's made a big difference. So as a leader, you know, once you know yourself, you know your organization, you know your team, now what are you going to do with those things? You know, what are you going to create as a leader? And I think it's essential to unify the team with a combined and shared vision. And in healthcare, that is generally, we're going to take great care of patients. And so I think that's often the vision, but it's great if it's a stated vision and also if it's lived in action. So you as the surgeon are saying, you know, I'm going to put patients first, and then your actions define that. And then if there's a disagreement among the team or something that you have to resolve, you can kind of take it back to first principles and say, you know, how can we work this out so we take the best care of patients? And I think this is part of, you know, as a leader, your job in motivating people. So instead of coming behind them with a stick saying, work faster or do this better, you can say, hey, we're all here to take great care of the patient. How can I help you, you know, do your job as a nurse better? Or like, what do you feel like is standing in the way of your job? How can I help? And this is a little matrix that I love. This is from Adam Grant. He talks about the tough love matrix of leadership and also parenting, where you talk about two components, care and expectations. And I think this is very fitting for physicians, where you're thinking about, are you low care or high care? And hopefully you're somebody who cares a lot, you know, who's like Dr. Webb, Dr. Brosen, you're doing a lot of very meticulous preoperative planning, meeting with the patient multiple times. And then I think sometimes as a young surgeon, you often have very high expectations of yourself, but sometimes it can be hard to have high expectations of others. And so what I would encourage you to do as a young leader is to have high care and also high expectations. And that kind of puts you in Adam Grant's inspiring category. And what I would like to say is prepare to adhere to your standards. So you're young, you're coming in, you may not know all your preferences yet, but maybe you have some things that really matter to you. And so be prepared to stand up for your standards and for the quality that matters to you and your patient. And so you can have some phrases in the back of your mind, like, I get that Dr. So-and-so does it that way, but here, I'm here now and I prefer to do it this way. And these are my reasons. And so if someone challenges you, you don't have to just fold. You can say also things like, I understand not everyone requires this as part of their pre-op workup, but it's important to me in my clinical care of this patient because of these reasons. And especially as a young surgeon, you want to be nice, you want to be friendly, but just don't confuse being nice with tolerating poor behavior or poor performance or low expectations. So coach yourself as a leader to be high care, kind, but also fair and holding your team to a high standard. And I think that can be done. It can be done without losing your temper. You just need to typically prepare for these conversations and prepare to hold your ground if you get challenged. So the number 5 is manage day-to-day operations of people and tasks. So these are some things like coaching, delegating, planning, goal setting, motivating. So these are things like on a day-to-day basis, saying hi to your team, having a positive attitude, coming into the OR saying, hey, thanks for coming into work today. Great to see you. Sitting down with your team members whatever you decide, every month, every quarter, especially if you have people that report directly to you, make sure that you are helping them achieve their goals. So again, if your nurse practitioner wants more independent clinic time, help set that up for him or her and then follow up on how that's going. Was it a success? Is it not a success? What's going well? What's not going well? And help facilitate things on your team that help other people, because sometimes, maybe one of your reports is struggling to get something done, and that's something that you can assist them with to get done much faster. So this is something from Stephen Covey, an idea that he popularized, the circle or sphere of influence. And I think this is important for young leaders, but you understand, there are some things within your control and then some things outside of your control. But over time, you actually try to push your sphere of influence further and further. So, every day you go into the OR, every day you go into work, every day you talk to somebody, you try to just gently expand your sphere of influence. And I think this happens in good leaders by, leading by example, understanding what your team needs, understanding your superiors, and letting go of things that are truly beyond your control, but trying to kind of take the next step and take things under your wing to expand the things that are in your sphere of influence, so you can make the biggest difference for your team down the road. So I wanted to talk about just 2 quick real life examples, and these can go, we could talk about these for a long time. But it's nice to just kind of think about these things here. So one real life example, you're just finishing up spine fellowship, you're joining a private group, you have one existing spine partner. You are now going to be in charge of a medical assistant and a nurse. And these people were hired, they're there for you, they're assigned to you, they were already there, and they're shared by your partner. So you and your partner kind of split clinic days, and these are clinic staff. So you share them 5 days a week. And then you'd like to hire an APP, PA or nurse practitioner within 2 years, pending your clinic volume. And so I think, hopefully you know yourself. That's kind of, know how you're going to react in this situation, and know your organization. You have one key spine partner here. Make sure you're on the same page as him or her with the expectations of your CMA and your nurse. For example, in bigger organizations, oftentimes different surgeons have different expectations of MAs and nurses, which leads to big problems when a nurse calls in sick and another nurse is cross-covering, and then that nurse doesn't do the same thing that the other nurse did. And so balls are dropped. And so if this is a team of 2 that you're going to be sharing with your partner, make sure you understand what the shared expectations are for that role and that you're on the same page. And then, know your team members, talked about knowing their roles, but then also understand, have they been there a long time? Do they want to leave? Are they imminently leaving? Is there something they're unhappy with about their current job that you can help them with? Do they really like your senior partner and they're just gonna hate you from the beginning? Do you need to kind of win them over a little bit? And then lastly, setting the vision as well as managing day-to-day operations. I think in this case, you set the vision of taking great patient care. How do we do this? This is how I see your role and how we achieve this shared vision together. And then the day-to-day tasks. So if you start working with this team and they do some things well, but other things not well, you can keep track of those small things and say, hey, it's been great working with you so far. For my preferences and my practice, these are a few things that I wonder if we could do differently, and try to coach that person to meet your hopefully high expectations. And then the last real life example that I wanted to talk about is, the classic opposite. So you're a new hire now at an academic institution with 2 sites that you kind of split your time between. And at one site, you have one nurse practitioner, an on-service resident that's shared between you and another spine faculty member, as well as spine fellows. And then at your second site, you also have residents assigned to your service, as well as 4 PAs that are split between general ortho and spine. And all these people, so all the nurse practitioners and PAs have been hired by your institution. They're there before you. And unlike private practice, you don't necessarily get to hire or fire them. So how do you get this person on your team? You are their leader, they do report to you, but you're not really in charge of them as their boss in a sense of the administration. They actually usually report to like a lead nurse practitioner or lead PA. And so just thinking about those 4 things again, know yourself. Why did you take this academic job in the first place? And one reason hopefully is because you love working in big teams and you like teaching and coaching. Know your organization. This is a big institution. It's not going to make big changes. You usually want to come in and understand how the system works, and then try to slowly make incremental changes that you think are beneficial, as opposed to coming in really hot and trying to make in a bunch of changes and them all kind of blow back onto you. Know your team members. These are people that were there before you. They actually have more experience in this system than you do, even though you're coming in as their superior. So it's very important to sit down with them and say, hey, what's going well? I'm coming in here, I'm new. What insights can you give me? How can I help you do your job better? And, continue to get feedback as you go on in your role and learn. And then vision and trajectory. Again, I think it's about taking great care of patients. If you have a vision to focus operative teaching on the residents and fellows and have some service obligations assigned to the nurse practitioner, then you need to make that clear. You need to make sure all team members are on board. Who's answering the day pager, who's answering the overnight calls, who's doing the consents. All these things should kind of tie back into your vision, and hopefully you can get everyone on your team on board. And then finally, just managing these things day to day as small issues come up. All right, well, thanks everybody for listening, and we look forward to transitioning to questions here.
Awesome. Thanks, Dr. Hobson. So 2 great talks that for those of you that aren't there yet, you'll see when you get there. A lot of this is just kind of coming at you all at once when you're finally in charge and you just have people asking you questions like how you want to do things. And it's helpful to think about this stuff ahead of time. I wanted to ask you something, Dr. Hobson, that is a little unique to your situation, but I think a lot of us think about. And that's when you're in your training program, residency or fellowship, the people there, you're comfortable. Hopefully they like you, and let's say you get offered a job to come back after your fellowship, or you're in fellowship and you get offered a job there. I know one of the thoughts all of us have is that would be great, but I'm Dr. Hobson, the resident, and if I come back, I'm going to be Dr. Hobson, the attending. How does that, at least in your experience, how did that change things? Was that an easy transition? Did you have to remind some people that maybe felt like when they last saw you, you were a resident, in terms of now you being in charge of the team?
Yeah, I think that's a great question. And so for people that don't know, I did my residency at Emory. I did my fellowship elsewhere, and then I came back to Emory to join the faculty. And I had my chairman tell me, if you come back and you behave like a resident, you'll be treated like a resident. And if you come back and you behave like an attending, you'll be treated like an attending. So you need to set the expectation for team behavior. I think my personal leadership style that I try to embody is to lead by example. And so I think in any career, whether it's medicine or not, I think that you grow into each role and you gain people's respect by just the things you do each day. So for me, every single day, I just do the absolute best I can. And I try to answer people's questions. I'm in charge. I try to lead the team well. I think I try to take input from people, but at the same time, if there's a final decision, it's still my call. And ultimately, the patient's outcome is on my shoulders. And I understand that. And I think, thankfully, most people have seemed to step in on the team. And I think that's helped by the fact that I'm less of a top-down leader and hopefully more of a leader by example. But I think you could certainly get into situations where you go back to where you were for residency and you have a little bit of trouble stepping out of the training role.
Absolutely. Thank you for that. Dr. Webb, this one's for you. You were talking about kind of taking notes for the steps that you're going to do in the surgery, which I think is a great idea. And every time I've done that, I've appreciated that. The question though is about things that you do different as an attending and about like your clinic notes. Like I'll tell you, for instance, for me, I found that I start writing myself more notes in my note, like, hey, next time they come back, let's discuss this. Like I was thinking about disc replacement instead of a fusion for this patient or whatever. Is there anything in the pre-op planning and the clinic stage that you do different than you did when you were a resident or a fellow?
Well, I think as a resident or fellow, you are kind of looking at those things and looking at the patient's labs and their preoperative clearance. But it's pretty similar to you. I put notes in the patient's chart in terms of things that need to be followed up on, whether the patient, I take really good account of their social history as well. I have a patient from, he lives in Carthage, Texas, that flew in to see me, but he needs surgery, but he lives alone. So his social situation is really worries me about traveling here to have surgery and then having to go back. So I make note of those things in the patient's chart. And also any, like if they're going out of town for a couple of weeks and then coming back to see me, so that when the next time that I see them, I can just say, hey, how was your trip to Paris or to Chicago? And patients really like that. It makes them feel like they're, part of the family. And I try to make note of those things, especially things that need to be followed up on before surgery.
Yeah, I totally agree. I'll tell you, I didn't go to enough clinic as a resident. I think a lot of residents kind of suffer from that. And I realized I didn't see a lot of patients in residency for 10 times. And they expect you to remember who they are now, which is totally reasonable, but something that I wasn't great at. So I think that's a good idea to note things about them as a person and things they're planning on doing. So the next one for Dr. Hobson. At an academic program like Emory, where there's kind of a real process for leadership and a hierarchy, is there any formal mentorship for leadership or courses or any way they kind of go about that in your experience? Or is it kind of like the things you're talking about you learn in the OR just with the team around you?
Yeah, that's a great question. I think one of the advantages of being at a huge institution is that there are a lot of resources even outside your department. So at the university, so I'm within the Department of Orthopedics, but there's actually whole divisions like faculty development programs. And then outside of that, there's leadership development programs. And some of them, they used to be in person. Now often they're on Zoom, but they go through anything from how to write a grant. And within our department, we even have a promotion committee. So the Department of Orthopedics at Emory has actually over 100 faculty members. So we're a fairly large department here. And because of that, and because the promotion process for academics, and so that's when you go from assistant professor to associate professor to full professor, can be really complicated. And a lot of it is very self-driven. So even for that, the university, or actually our specific department, put together a small group to help people with promotion related activities. How do you track your promotion related activities? When are you eligible to apply for promotion? When should you apply for a promotion? Should you apply as soon as you're eligible, or should you look for one or two more things? And I think, in all honesty, it's kind of just hard to take advantage of all of them because, of all my clinical work. But I feel very thankful. And I think that's one of the great things about working for a big academic institution is that, at least at Emory, they put a lot of effort into making those resources available for people that are interested.
Excellent. Dr. Webb, I'm going to put our friendship on the line here a little bit with this question I'm about to ask you. When you were talking about pre-op planning in the case you just presented, I was pretty honest with you that I don't know that I would have caught that and thought about getting a CTA. Can you think of a time, residency, fellowship, out now, when you got into something, maybe not as bad as that, but where you thought, I should have done this before, you realized maybe you missed something in your planning getting into the case? And if so, how'd you get around it?
That's a great question. I can't think of any particular case kind of back to residency, but I guess out in practice, for me, I'm a very conservative surgeon, kind of picked this up along the way, and patients really have to show me that they really want surgery and make sure we fail everything, but kind of the conservative route before surgery. But I would probably say maybe one patient just doing a decompression, a hemilaminotomy, that I should probably just have confirmed maybe an additional time with an injection. I was busy taking call and had this case scheduled and a lot of other things going on, and I should have really paid attention to just that injection to be sure that her pain was coming from that level, which ultimately she did well and her pain went away. But going into the case, I was questioning myself, about, man, I hope this pain is actually coming from this level and her leg pain will go away with this case. But just double check, triple check. It's always sometimes the patients come in with injections and they're kind of, I think it was a L4, L5 or L5S1. I'll still send them to a pain doctor just to triple check to be on the safe side before surgery. So.
Yeah, no, I love that. And I think, when you were talking about stuff in the operating room with the team, and Dr. Hobson mentioned some of this too. But one of the things I started doing is, man, on our little whiteboard where they write, how many sharps and all that, I make them write really big, C4, C5. I mean, that whatever level is huge. I write it with a marker. I mean, the first time I did it, they laughed at me, but it's like, you start feeling this pressure since you're the attending, like, I'm the only one that's in this room that's shown up in the courtroom if this doesn't work out, So that's certainly changed the way I viewed some of the stuff just by being in charge in that way. And the last thing, what were you gonna say?
No, I was saying another thing is to go through a mental checklist in your head before you close. I always take a second and I'll stop even for 20, 30 seconds to just make sure, hey, check the nerve roots. Do I need to leave a drain? Did we torque all the screws? Do we have all of our end caps kind of accounted for? So that's something that I do before kind of closure. Take a second, and I even ask some of the OR techs or the the first assist, and hey, did we do everything? I'll go through that checklist in my head. So I think that's maybe something that people can pick up.
No, I think
and
that's a good idea. Go ahead.
Yeah, I was just going to chime in. When you were talking about the preoperative evaluation and being conservative and, making sure the symptoms are, in line with what you're doing surgically, especially in some of my practices, I'm kind of taking over from patients who have been previously cared for by others. And, your plan may not be the same as the previous person's plan. And I think that that's okay. And, maybe you want more conservative management. Had a patient come in and he had been told that he needed surgery, but it got delayed due to COVID. And then he had a very complicated psychiatric history and also had a history of like AAA repairs, some major vascular surgeries. And, he described his chief complaint as something that sounded classically like vascular claudication. And I said, I think you also have a little bit of neuroforaminal stenosis that's causing some radiating pain, but, it doesn't sound like that's your chief complaint. I think, we should either get those records of the injections you've had over a year ago or try another injection. And actually this guy got really angry with me. And, I felt bad for him because I think in a way he felt like he had been given the runaround, and was frustrated. And I can totally empathize with that standpoint. But at the same time, you don't want to be the person who does the surgery and the patient doesn't get any better. I don't feel like I ever want to be in that position. So I think, it's okay if you meet somebody for the first time and, your plan isn't the same as the previous person's plan. And I also think, at least for myself, in some of my more complex practice environments, you meet someone multiple times and you kind of learn some new stuff each time you meet them.
Yeah.
And it's okay to kind of have iterative thoughts as you keep meeting them, kind of like Dr. Webb was discussing. That patient, it was looking like multiple myeloma for a while, but there's new information. And I think I always tell myself, it's a sign of intelligence to change your mind in the setting of new information. So don't be afraid to seek out new information or change your mind if you follow the patient serially in the office, for sure.
Well, and the big thing with that problem of a patient who wants a surgery for whatever situation, and you're now saying you don't want to do that, whether you had promised it or someone else had, the line I keep going back to that's the common denominator for all human beings, really, at least in the US, is I just tell people, I put food on the table by operating. So if I'm telling you you don't need surgery, it's not me being selfish. It's the other way around, and most people with that back off a little bit. They kind of understand and they're frustrated, like you said, and they'll kind of admit that, sorry, I just feel like I've been jerked around, but it's an easy way to make it clear to them. Like, I do this because I like it and I get paid to do it. So if I'm not offering it, there's probably a good reason for that. The other comment I was going to make on Dr. Webb's checklist is I gave mine my operative checklist with all the steps to my rep. And I like my rep, he's in all my cases, but I asked him, did we do all those things? And I will admit to you, I do that because of a mistake, like where most checklists come from. I did a T10 in the pelvis with another surgeon. We were exhausted. It's like a 10-hour case. We'd already done the front stage a couple of days before. We got all the instrumentation in. We did the posterior osteotomies. We did the S2AI. We did the SI bone implants. We got the rods bent. My top 4 screws were percutaneous. So we got the rods snaked up there. We got the facets burred through the tiny holes, did all this stuff, get it closed up. We're like too tired to even high five. We're just excited, nothing bad's happening. And when we leave, we were talking about it later, and we're like, we didn't put a drain in. And like, it's a T10 in the pelvis. Now, granted, we only opened from like L1 down, but it's big enough that there's no reason we shouldn't put a drain in. And more importantly, we intended to. So we can fool anybody else. We can't fool ourselves. That was a mistake. And it was made because we were tired and whatever, all these other excuses that shouldn't exist. So we tried to put that process in place where now my rep will ask me, did you tighten the set screws? Did you do that Smith Pete you were going to do or whatever? And it's really helped. So I wish we'd had this talk a few months ago and Webb would have taught me that and that lady would have got a drain, but she did okay. So it worked out. I think, we're about out of time. Okay, well, I want to thank everyone for coming today. People that have stuck around. We're 5 lectures into this, and we were talking before, we're kind of, our minds are blown that it's already May now. We have 7 more of these this year. We're really excited about the talks we have coming up. We've kind of organized the next 4 or 5 already. If you're interested in talking or know someone else that is, we still have a few slots open. If there's ideas that you have or that you'd like to hear more about, please tell us. Otherwise, we'll be talking about a ton of different things, and we'll try to get a longer schedule out to you guys so you kind of know what's coming and can tune in the future. But big thanks to Dr. Hobson and Dr. Webb for their talk tonight. And thank you to everybody else for joining us. So, thanks, guys.
Thanks, John. Have a good night.